Well, good morning, everybody, and welcome. My name is Tatiana Shippey. I am an Associate Director for Research at the Center for Healthy Aging and Innovation, and I'm an Associate Professor in a Division of Health Policy and Management at the School of Public Health. Now, before I introduce our speaker today, I would like to open our session with a land acknowledgement. Every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. Some were brought here against their will, some were drawn to leave their distant homes in hope of a better life, and some have lived on this land for more generations than can be counted. Truth and acknowledgement are critical to building mutual respect and connections across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We are standing on the ancestral lands of the Dakota people. We want to acknowledge the Ojibwe, the Ho-Chunk, and the other nations of people who also called this place home. We pay respects to their elders, past and present. Please take a moment to consider the treaties made by the tribal nations that entitle non-Native people to live and work on traditional Native lands. Consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truth at any and all public events. And with that, let me introduce our inaugural external speaker for CHAI, Dr. Roland Thorpe. Dr. Thorpe is a social epidemiologist and gerontologist whose research agenda focuses on understanding how key social determinants of health, such as race, socioeconomic status, and segregation, affect health and functional outcomes among men across the life course. He serves as principal investigator of the Race Disparities in Mobility Disability Among Men project, National Black Men's Health Pilot Study, and the Black Men's Health Accrual project. His work appears in flagship journals in the field. Dr. Thorpe is also actively involved in dissemination of research to promote translation into effective programs and policies that advance the goals of reducing health disparities. He's also an outstanding mentor and has been recognized by Gerontological Society of America with Outstanding Mentor Award for 2020. And also most recently, I don't know how he has time to do anything else, but he was appointed as chair of the Gerontological Society of America's Diversity and Justice Working Group that is aiming to promote equity across the whole society. So on a personal note, I've had the honor and privilege of knowing Dr. Thorpe as a friend and mentor since graduate school. He is truly a role model for me and a visionary, and we're so lucky to have him today. So before I hand this up to him, just the last couple minutes of housekeeping. Please use the Q&A function in Zoom to post your questions throughout Dr. Thorpe's talk so he can address those. But also you're welcome to use the chat to just share your general comments and reflections about the talk. So with that, let me hand it off to Dr. Thorpe. Thank you, Roland.
Thank you. Let me get the share screen together. Okay. All right. Okay, so first of all, thank you, Tatiana, and the entire leadership at the Center for Healthy Aging and Innovation for this opportunity to speak with you today. I am so glad, and I was very delighted to hear the land grant acknowledgement, which what a powerful way to start this this presentation. So what I want to do today in the time that I have, I want to talk about health equity and aging today. And so what I'll do is I'll set up the conversation around health equity and aging, and then I'll talk about some of the things I think we need to do to move forward to achieve that health equity. All right, so as you might imagine, or you might remember, we're in the midst of a very interesting time in the United States. In addition to the pandemic and social unrest, we're also undergoing a demographic transition whereby that we will become a nation where the minorities that will be the majority groups in the United States. And as we do that, as this demographic transition occurs, the health statistics, as you might imagine, will become a reflection of the health status of largely racial minorities in the United States. And so what we know about health disparities today will largely become the nation's health. And in addition to that, We'll also see, in addition, what we've known is that there will be more racial diversity among the older segment of the population, 65 years and older, and the impact of this demographic shift on society as a whole will, and on society as a whole and the healthcare system will, and particularly, will be driven by declines in level of function and declines in one's ability to carry out daily tasks, and declines in cognition that may lead to dementia-related disorders altogether. But so, how do we deal with these wildly known disparities? I decided to save all of us the horror story of marching through shore and you grab some pictures of the disparities that exist, because I no longer want to stigmatize those populations that have those horrific profiles. What I want to do is for us to talk about a way to move toward achieving health equity and bettering the outcomes of those who might currently have poor health outcomes and health indicators now. One popular approach to addressing health disparities and achieving health equity is that through the social determinants of health. And when I talk about social determinants of health, I'm actually talking about those health conditions in which we live, work, play, pray, and age. And a lot of these health conditions can include, a lot of these conditions can include one's working conditions, access to essential goods and services such as water, sanitation, housing, and food, and access to good quality health care. In fact, when we think about the factors that impact our health and well-being, we see that approximately 80% of the factors that impact one's health is largely related to social aspects of health here in this picture. So given that background, the motivation, then I would like to spend the remainder of my time focusing on discussing these, what I believe, key factors that can help us move toward achieving health equity in aging. So I'll go ahead and start with the very first one. As we can see, while we have these social determinants of health, these social determinants of health are largely driven by structural racism as it is today. So these conditions, the working conditions, the underemployment and unemployment, and access to good quality healthcare and housing is largely driven by inequities that are oftentimes experienced by disadvantaged communities. And then it is within these disadvantaged communities that are largely linked to segregation that leads to a lot of these poor health outcomes and adverse health outcomes that typically require community level and system level responses. And we'll talk about some of those, some ways to potentially move forward and address those here shortly. And so when I talk about racism, I just want to put, because there are a number of different definitions that are available. So when I talk about racism, this is a definition that I use by Williams and Muhammad. It's an organization that's premised on the classification and ranking of social groups into races. And what most importantly, this system devalues and disempowers and differentially allocates opportunities and resources to racial groups that are regarded as inferior. So that's the definition I operate under when I talk about racism. And as racism relates to aging, racism relates to aging in two ways. There are indirect ways, and then there's known direct ways in the literature. The indirect way is oftentimes there's racism it restricts your socioeconomic attainment for people typically in minority groups, and then that restriction of education attainment can lead to poor health outcomes over the life course. And then the direct effects it's also known in the literature that exposure to this racism and discrimination, it directly affects your health. There's been work to show that in older adults that discrimination and racism has been linked to hypertension, it's been linked to obesity and cardiovascular disease. But the problem here is when we think about racism and aging, oftentimes what has occurred in the literature is that racism has been seen somewhat as static and it hasn't been modeled over time. And we know little about its dynamic impact across the life course, and understanding its dynamic and impact across the life course could shed some insight to our further learning about how we can move toward dismantling racism and moving toward achieving health equity. Now here's a graphic of the or here's a picture of the that I typically like. Comes from the allegories from the work Dr. Kamara Jones. She wrote a paper in 2000 about the Gardener's Tale, where she describes 3 types of discrimination, and these 3 types of discrimination and how they operate differently. One of the things that when we think about using these different types of discrimination, when we think about the literature as it stands now, we don't oftentimes look at all 3 types or the synergistic effects of all 3 types of discrimination. We typically largely either look at interpersonal discrimination or institutional discrimination, and we rarely look at internalized discrimination. But I think we know some about institutional discrimination in the form of segregation. We know a lot about that in the literature, particularly as it relates to aging and among older adults. But we don't know what I think the next step to achieving and dismantling this discrimination is to understand how these operate independently and together to impact health outcomes in late life or in mid to late life. And as we think about racism over the life course, my colleagues and I have, we recently published a couple years ago a framework that we articulated how institutionalized racism and social determinants of health, how they impact aging. And as you can see here, this framework integrates institutionalized racism and health. And specifically, we look at the impact on racism on age-related health outcomes. And it's through a number of socially disadvantaged positioning that actually heavily influences the persistent disparities in the receipt of quality care, many chronic conditions that can then lead, these chronic conditions can then lead to these increased allostatic load and reduced telomere length and premature chronic conditions and ultimately premature mortality. And this also highlights the role that social cultural factors need to be their attention needs to be given to social cultural factors such as unconscious providers bias and how that may impact differential clinical practice and decision making. And then medical mistrust and related factors also impact patients' beliefs. And these are some of the things that oftentimes are not captured in some of the data sets that we actually use when we try to think about understanding how something like institutionalized racism, how it may impact aging and health outcomes later in life. And we provide this frameworks in hopes that people will give people a broader sense of the more nuances that we need to look at as it relates to understanding internalized racism and the social determinants of health and aging. Here, I want to bring attention to one of a project that I'm currently working on with colleagues at around the country. Dr. Sarah Zanton is the lead PI on it, and as I'm a PI on this reducing racial disparities in ADRD. Our goal here is to address structural racism and discrimination. One of the things that we have been funded to do is to create a measure of structural discrimination and a measure of structural resilience. And we've currently started working on our measure of structural discrimination. And I would tell you that the more we delve into it, the more we peel back the layers, the more we see the more work that needs to be done. One of the things around this measure of structural discrimination that we want to create is that we want to account for different domains and different domains of one's life. For example, we want to look at the education, we want to look at the employment, we want to look at civic engagement, we want to look at their ability to have public transportation. There's just a few of the different domains that we're seeking to try to include in our measurement of structural discrimination. And the idea behind this is to create the measure, test it, the measure, and then once the measure is validated, then we will want to get this measure into large epidemiologic studies, so then we could have a measure of structural discrimination, and we'll be able to examine the impact of structural discrimination, potentially with individual level discrimination that is typically already in many of these large cohort studies, and to be able to think about how to learn from observational studies, how we can glean from that information to be able to think about intervention development. So we're very excited about this opportunity to be able to work on this complex but much needed problem that will be able to, we're hope to give us an opportunity to start moving us and advancing us toward achieving health equity. Now, another approach that I think is very important for us to think about health equity and aging is the importance of a life course approach to understanding this. The life course approach provides us a great opportunity to examine earlier life experiences. We can assess the impact of time and duration of these life experiences and how they may impact the mid to later life outcomes. Now, we've learned a lot about cohort studies that start at 65, but as it relates to understanding achieving health equity, I believe that cohort studies that begin at 65 are left censored for people of color, particularly African Americans and African American men who have high rates of premature mortality. And so this degree to which this premature mortality occurs, it varies by key social determinants of health, as one might imagine. So as a result of this, we would see that the influence of social, behavioral, and environmental exposures, they will be grossly underestimated as it relates to trying to understand health equity across the life course. And I always say that, when we think about these studies, the assumption, oftentimes the studies rarely ask about past life experiences, even though we're starting at 65. People just don't show up at 65 and be unhealthy. It's the accumulation of their life experiences that's oftentimes omitted in these studies. So it's a missed opportunity for us to really understand how we have an opportunity to understand how groups that don't necessarily, we wouldn't expect to make it to 65, such as Black men, how did they get there? We can learn some from a strength-based approach oftentimes, but there's a missed opportunity when we don't collect those data for early life experiences. And then the other thing that I think for me that the life course approach affords the opportunity is that it forces us to follow people over time, and we can obtain information, in real time, as opposed to asking people to think back some years and get the information. If we can get things as they occur in real time, I think it will be much better. Now, this would call for additional data sets, additional studies to occur, longitudinal studies to occur with that, with the type of work in mind. But if we're trying to really move forward to understanding health equity and advanced health equity and understanding how the aging process can be improved, then I think this is one of the ways in which we can think about moving toward that. But it will cost some resources to be put in place to do this, and we'll have a better understanding of where we are. Here is a paper by a colleague of mine, Dr. Gil G, led by Dr. Gil G, and I think this paper is an outstanding paper. If you haven't read it, this paper literally talks about the life course perspective and share with you how the different parts of the life course perspective and tenets of a life course perspective and how racism can influence those life course perspectives over time. And I think I found this paper, it was published in 2012, and I find myself rereading it at least once a year. It's a very well written paper, and it links different points in the life course. It actually delves deeper into the different points in the life course and how racism, structural racism and individual racism, how it can impact health outcomes later on in life. And so if you have, that's a shameless plug for Gil's paper. Please take a read if you haven't read it. Now, another issue to approaching health equity is methodological issues. We have a couple methodological issues that I think that we have to rectify in order to move forward to trying to achieve health equity and aging. The first one is that we got to have an increased focus and attention on recruitment and retention of racial ethnic minorities in studies: retention and recruitment. Oftentimes there's an emphasis on recruitment and not a lot on retention. We need both recruitment and attention. And to understand that the approaches to recruitment might need to be different based on different racial ethnic groups. It shouldn't be a one size fit all. And then we need to think about, as we're thinking about this recruitment and retention effort, we need to think it's going to require us to build relationships. We may not be able to do the what we've always done in the past, which may not be these multi-stage complex sample design. That may not work well for getting a larger number of people of color into the samples. We need to understand that, recognize that, and embrace that, and have flexibility in our approach without minimizing too much rigor to the study design, but having the flexibility to understand that if we want to recruit and retain racial ethnic minorities, we may have to use slightly different approaches to do that. And we can learn a lot, and we have learned a lot on the CBPR principles. They're great for guiding us to do this. And it's important that we have to have these different racial ethnic groups in our studies, because remember earlier, the first slide I showed you is that we're becoming a nation where the minorities will be the majority. And then as a result, we want to, the nation's health will reflect that largely of the minorities. And so we want to make sure we have sufficient number of people of color in our studies so that the work can be appropriately generalized to those groups. Now, the second area that I think is important is this notion of the importance of studying within group research. I think that from my perspective, from on the major health indicators and health outcomes, we know that there are differences. So we know that the people of color by and large do worse on many of the health outcomes, but we need to move beyond that to examine within group to better understand the significant geographic and cultural and behavioral and SES differences within these groups, to have a better understanding. And a way to do that is to study within groups. And with studying within groups, it's okay not to have a comparison group. In fact, that's where I think we can learn more. We can better understand mechanisms and pathways of how things operate within a group. And if we understand that and we can improve their health, we will be addressing and closing the gap, the disparities gap that has been observed and documented for a number of years. I think that we should take full advantage of the diversity in our population and have the flexibility to think about these groups as being different, and they don't have to necessarily be compared to what we believe a quote unquote reference group is. And my philosophy behind the reference group: who says it has to be a white person? Who says it has to be the white man? Or who says it has to be the largest group? So those are some things I think that we think that we need to move forward on and embrace the within group research. Now, the third area we need to advance our understanding on is this idea of employing qualitative and mixed methods research. I think it's extremely important for us to be able to engage that because we now know, and we're now learning, particularly among older adults, particularly when we think about racism and discrimination. I think it's extremely important to be able to understand people's lived experiences and how their lived experiences has impacted their beliefs around things, which ultimately may lead to how they engage or not engage different organizations such as the healthcare system. And I think being able to have that flexibility and being able to engage in the qualitative research will be very, very important. And also, if you want to do, I think mixed methods approach is also as good as well. I just want to make sure that we don't leave out the qualitative work and the mixed methods research, because I think it's very important, and it helps us get a better context on sometimes what people just answer on surveys. And so I think it's important. One of the things I'll say when we think about doing research, particularly on different racial ethnic groups, is important to understand their historical context and their lived experiences. And these methods afford us the opportunity to gain that better understanding and gain that better insight. And finally, the last methodological approach I think that will help us move toward health equity and aging is I think it can be very helpful to study generations or families within minority aging populations. And so when looking at minority aging populations, family methods and dynamics can lead to insights of how gene and gene environmental associations may interact, as well as we will be able to study sources of stress and sources of support. Family designs, such as twin studies, they're seldom used in health disparities research. And I think that represents a missed opportunity to fully understand potential disparities that may exist so that we may be able to move forward to achieving health equity. One such study that a family design study that I'm a part of now is the study of longevity and stress in African Americans. We call it the solsa study. Dr. Keith Whitfield and myself are the multiple PIs on this. Our overall goal of this project is we want to study patterns of perceived stress, active coping styles, health status, and genes that contribute to longevity in observed African American families. And our specific aims are as follows. We want to look at similarities and differences in stress and coping among sibling pairs and across generations within families. We also want to look at the concordance of health status among siblings and various levels of stress and coping. And then we want to also understand how genes are associated with stress and longevity, comparing across families, long-lived families and short-lived families, and among siblings. And so our research design, we have a rather, we're excited about the unique research design that we have. It's an intergenerational family study. We're going to collect, our goal is to collect data on 750 individuals. Our topology that we use for families, and we have long-lived families, and a long-lived family is a family that has a living parent and two siblings. And then we have short-lived family, and the short-lived family has no surviving parent. And then we also have singletons in our study, and they're old adults who have no children. So what we have done to date is we've collected 600 information on 640 individuals, 105 long-lived families, 148 short-lived families. And we have 29 singletons in this study that are greater than 85 years of age. And our recruitment approach was a recruitment approach that Dr. Whitfield used in his twin studies in the early 2000s. We used Carolina. The study is based in North Carolina. We used North Carolina voter registration records, and we actually used 6 counties that had contained the largest amount of African American populations, and we found 2,033, a little over 230,000 records for individuals 50 and older, of which 44% were men. And then among those 70 and older, we found a little over 77,000 records. And so what happens is these records contain phone numbers and addresses, and then we go from there and we reach out to people using the phone numbers. If the phone numbers aren't working, then we would look at the associated white pages to assist us with finding people. We've been very successful so far. We are moving toward finishing up our data collection. Here are a list of different instruments that we have that reflect these different concepts in yellow. These are the instruments that we're doing, that we're collecting data on. We're excited that we will have a lot of information on using this family design to afford us the opportunity to understand how the gene and the environment may interact with families and across generations. And we can look at coping styles and different sources of stress. One of the beautiful things about the family design is that this family design affords us the opportunity to have a number of different comparisons. We can look at siblings from sibling 1 to sibling 2. We can look at a family effect, the long-lived family versus the short-lived family as it relates to the siblings. And then we can look at a generational effect, the parent versus the sibling effect. It affords us different opportunities to do different types of analyses. Now, this type of study doesn't go without its challenges. So one of the key challenges here is that there's a complexity of disentangling the contribution of genes and environment to our understanding of health disparities, and then measurements of health across generations have been modified by social change. Example with our group is education, desegregation of education. And then there's this complex interrelationships between SES, culture and behavior, and genes over time that that will challenge us. And then finally, we also have the idea of identifying causal pathways to health and disease and how to eliminate these disadvantages across these different racial ethnic groups. So we need to take into account where the people lived and where they lived, and do they have access to fruits and vegetables? Do they eat them? Do they live in nice neighborhoods? Now, there are some opportunities here. So the forces the opportunity to understand discrimination on family, how discrimination impacts family, that ultimately produces health outcomes. And then also affords us the opportunity, like I said earlier, to understand how genes are impacted by the environment. So we're very excited about both the challenges that are in front of us, but we're excited, we're equally excited about the opportunities that what these data may afford us moving forward. Now, the last opportunity, the last approach that I think is very important for us to think about when we want to achieve health equity and aging is this diversifying the biomedical workforce. And so I think that's very important for us to be able to do such thing. But I think we got some work to do. We're going to have to increase the number of people of color in aging research. I think we're off to a good start with doing this. And I think that National Institutes on Health, and particularly National Institutes on Aging, has a number of different funding opportunities for us to actually increase the number of people of color in aging research. Also think another thing that we need to work on if we're trying to achieve health equity, and in addition to increasing the number of people of color in aging, we need to increase the training and translating evidence-based work into solutions. Oftentimes we get trained on how to answer our research question and put it in a journal, but we don't really get the work and translate it into solutions to get it to the communities that really need this on the ground. And we need to increase the training in that. We also need to increase the community involvement, get community members involved on how to approach the community and how to partner with the community. Oftentimes we as academicians think that we have the answers and we know how to engage the communities, and then when we actually don't. We need to sit down and have some flexibility to learn these communities and partner with the individuals in the community so that we have a better appreciation of what the community needs, and we need to come to some happy medium what we're trying to do and what the community needs are. And I think that we take that for granted oftentimes on how to engage the community. I think some training on how to engage the community from people in the community, not from other academicians, from people in the community who work in that area. I think that's where we need to be going. And we need to have, on the other side, I think, just slightly different. We should invite community members to become a part of our faculty to actually teach the courses, or teach some courses, or give some lectures on community involvement and aging. I think that would be wonderful to have someone come in out of the community who better knows the community than the people that live in the community, and have them come in and give some lectures or teach some courses, co-teach the courses with our academic professor, so that we can gain a better appreciation and gain a better understanding of how important it is to partner and engage with these communities. So that then, I think if we do these things, I think some of the approaches that I talked about earlier be a little easier, a little more straightforward as it relates to recruitment and potentially retention. I think it's just very important that we think about and keep at the forefront of our minds the importance. We're headed to a very excited area and very excited time in America, where we're about to become, again, this nation where the minorities will be the majority, and we need to make sure our biomedical workforce is ready to accept the challenge of continuing to achieve health equity. Finally, I'll give some concluding thoughts here. Is that achieving health equity and aging is something that could be realized, but we're going to have a greater interdisciplinary team. We no longer can afford the opportunity to work in silos. Those days are gone. We need to work together, interdisciplinary teams. And when I say interdisciplinary team, I am also including communities, involve stakeholders, a true interdisciplinary team at the beginning and all throughout the process, the research process and the dissemination processes of including community members throughout that process. The creation, I think the creation of the structural discrimination measure that we're working on, I think it can be a major contribution to the field of aging. We can then think about, afford us the opportunity to really think about how structural discrimination and interpersonal discrimination, how they impact health and well-being throughout the life course. And if we can we need to move beyond these methodological approaches that we have now to think about dealing with these dynamic nature of one's lived experiences across the life course, as well as one's how to put one's lived experiences in context and how to model these very dynamic things of the impact and influence of structural and interpersonal discrimination and racism on individual lives. And finally, the diversification of the workforce is very necessary for us to derive solutions, community-based solutions and policy-relevant solutions. I think if we can do these things, I think we'll be setting ourselves up for a better tomorrow. Thank you for your attention.
Thank you so much, Roland. That was amazing. I'm sure I'm echoing what others are thinking as well. And I really appreciate all of your comments, but I think what's very fitting for my next introduction is that we are very, very lucky here at CHAI to have Robin Frazier as the Associate Director for Equity and Community Engagement, who directly hails from the community and recently joined us just about 6 months ago. Prior to joining our team, Robin was the Director of Diversity and Inclusion at the Alzheimer's Association for Minnesota and North Dakota. So Robin, I'm going to hand it off to you to ask the first question.
Okay, thank you so much, Dr. Thorpe. I loved all those, adjustments that we could make. That's lots of opportunity. The first question that I have, Dr. Thorpe, is that we often talk about the larger body of literature being on race and health inequality. What is the status of research and literature that examines structuralized racism and health? And how do we grow that body of work?
So that's a very good question. And thank you for the question. And I'm so excited. This never happens that what I'm talking about, it comes into existence. So now we have a community person who come from the community leading the course. That is cool. So thank you so much. CHAI is ahead of the curve already. They got one of the things done out of the talk. So I think there is sufficient literature on race and health. I think we know enough that there are differences between different racial ethnic groups on a number of different health outcomes. I think we know that. I think, and I'm a proponent of moving beyond that, because all that does is continue to merely document differences. And it's to the point now, I believe it reifies or stigmatizes different groups who are doing poor. I think what we need to do now is to move to try to understand what is the driver for that. So the driver for that, one of the biggest drivers for that is structural racism that drives these different. So it's not race that really impacts your health, it's racism, right? Mm-hmm. That really impacts your health. We just don't, we didn't know how, one, we didn't want to deal with it early on. Two, now we're forced to deal with it and reckon with it head on. And so I think we are in a space now, there is growing literature. There has been literature on racism and health for a number of years. I think when I think of the leaders around racism health, I think like David Williams, he created this everyday discrimination scale. So there's David Williams, there's Tanae Lewis and David Chade that have written, Gil G has written largely on this, Elizabeth Bronono has written largely on this notion around racism or stress, or how stress and sources of stress impact discrimination. So we know a lot about that. But what I think we don't know, and where I think we can gain our greatest learning, is that much of that is the interpersonal discrimination. We know little about the structural discrimination. And I think in that paper I referenced earlier, I think Gil in his paper, Gilbert in his paper does talk about that. And I think we need to move forward thinking about the independent of interpersonal discrimination. What is the role or the function of structural discrimination on health outcomes? Because we know structural discrimination, structural racism, namely segregation. Segregation constrains your individual choices.
Thank you so much, Dr. Thorpe.
Okay, I'll ask another question. One of the many hats that Dr. Thorpe wears, as you could hear from my introduction, he is also an editor-in-chief of a journal called Ethnicity and Disease. If you're not familiar with it, I highly recommend you check it out. And I just put in chat a link to one of Dr. Thorpe's recent forwards in Ethnicity and Disease that talks about racism and the importance of recognizing racism. So with that, Dr. Thorpe, my question for you is that, thinking to that forward that you recently penned, what are some of the interventions or approaches or designs that you feel are good models for how this work should be done? You talked about sort of system level changes, but can you talk about maybe certain types of approaches that you think are more productive than others when really examining structural racism?
Yeah, so that's a good question. What I think is that when we're thinking about these interventions, the thing about these interventions, when you want to talk about structural interventions, for structural racism, they're going to have to be multi-level, right? And so they're going to have to be multi-level interventions. I think, well, the majority of them going to have to be multi-level. But the thing of it is, and my approach is that with those multi-levels, I think it's important to think about what is the intervention that you really want to test, and how does that intervention will impact those multiple levels, right? Oftentimes we see interventions at one level and then we're going to infer from there what happens at the next level. I think what we really want to do is we want to have interventions across these multiple levels. And I think the National Institute on Minority Health and Health Disparities has now put forth some different calls that are looking across these different levels, as well as National Health, Lung, and Blood Institute. They've done it in years past as well, to think about what are the structural interventions that you can put in place. But oftentimes when you do these structural interventions, we want to make sure that we also have something in place to account for these individual differences that people may have.
Thank you so much. Robin, do you want to ask the next question?
Yes, I'm looking in the Q&A and just encourage people to please use the Q&A function to ask Dr. Thorpe questions. So I have a question here, Dr. Thorpe, from Marty Dilemma, and she asked, what specific measures or questions do you recommend to gather information on a person's experience of structural racism?
So yeah, that's a good question. So for me, that's a beautiful example of a space where you can do qualitative research, right? I think that's one of the most beautiful things you can do. So one of the things that what we've done is that we've had some focus groups, some structured interviews with older adults, older African-American adults across different ages, I think from 50 and up. And the questions we've asked, or we start asking them about their lived experiences and how their lived experiences have changed throughout time. And we go and we talk about segregation, because when you're talking about African Americans, particularly in the United States, it's segregation, Jim Crow, those types of things. You ask them about Jim Crow era, the civil rights movement, and things like that. What we found is that they'll start to open up and start telling you about those experiences. And it's very powerful. So you need to be ready when you go ask those questions, because it's very, very powerful going with respect to going there. But I don't know who the person is, I don't remember, and I apologize. But if you send me an email, we'll be willing to share our questions that may be helpful for you and it may not, but we'll be willing to share it with you.
Okay.
Thank you, Roland.
Can you put my email in the chat? Or can I do it?
Yeah, I can do that as well if you are answering questions. The second question we have also from Dr. Marty DeLima on what is your advice on how to enhance participant retention?
So mine is, because I largely study, focus on African-American, as of late, African-American men. Mine is I engage them in things that they, I engage them in things that of interest to them, with retention. So, you can do the things that are normally done that I've seen is that engaging people in research studies that you could, you send uh, birthday cards or e-birthday cards, depending on the mode in which you're operating, communicating with them. We send that, and then we have also sent out newsletters, and we've also sent out newsletters, birthday cards, and the other thing that we've done is that we typically try to send them some information, but all the information isn't research based. So what we've done is the people that are in the study, we got permission to engage them between sessions. And so the people that are in the study, we ask them, is there anything that you want to hear about in between data collections? And what they want to hear about, we either we would have a presentation for them, or we put together some kind of infographic or some information and get the information back to them. And so then we do this during the process, during the research process. And I found that then when I'm asking them to answer these questions on the survey, they don't feel like, oh, he just wants to get this information from me. And also the other thing we do is we summarize the information on a yearly basis, and we send them out a note, and we have typically we have now we had a Zoom of sharing the findings to them. And then for the group of had a group of younger men, we were doing some when we were doing focus groups, and we were doing them at 2 different time points. It just so happened those 2 different time points spread across March Madness. So we created a March Madness bracket with them. Everybody was engaged. And so it was, it wasn't about, all of the health stuff. We were talking about basketball, and you learn a lot about, the different chatter on, we created a group me. And so everybody's talking trash about their teams that were losing, and it created some camaraderie there. So I think you just have to think, innovatively how to engage people, but make sure you get IRB approval.
Okay.
Yes.
Okay, thank you, Dr. Thorpe. We have another commenting question. It says, thank you, Dr. Thorpe. That was fascinating. I would love to hear more about the use of voter registration in targeting your survey participants. When we are trying to connect with the different racial groups for survey participation, it is very difficult to reach those groups unless we are already serving them, thus eliminating the people that we are not reaching.
Yeah. So what we've done, the great question, is that what we did was we used the voter registration as a sampling frame. There's pros and cons to that, and then there's generalizability issues to that. And we understand external validity may be dampened, but we recognize that. But what we've done is that we don't get a lot of we've been fortunate enough not to get a lot of turn down. What we do get a lot of is a lot of people phone numbers have changed. Those numbers aren't working, because remember, most of those voter registrations, many of them were the people that were not getting their landlines, and people are moving away from landlines now. But for the younger group, for the siblings, we were having difficulties with the landlines, but for the older adults, they typically, particularly in North Carolina, they would have landlines. So the idea is that we never had too much of a problem of people not wanting to participate once we got them on the call. But the work is being done out of it's been run out of Duke University, and my understanding is that Duke University has an outstanding reputation now around research in that area, in those areas. So that has helped us a lot. And of that, I can imagine if they didn't, it would probably have been a little more difficult. And we've had recruiters that live in that area. And so the people that we have live in the area, and they know that area.
Thank you.
Thank you.
Thorpe. We have maybe 5 minutes left because we want to make sure that Dr. Thorpe gets a break before his next talk. But maybe I'll just quickly take a question from Dr. Neil Henderson. He's asking, how can political-economic resistance to improving health equity for non-majority populations at all ages be addressed?
How can political
economic resistance, political economic resistance to improving health equity for non-majority populations at all ages be addressed?
Oh, yeah. So that, to me, that's easy. Go out and change the political landscape, right? That's one way to do it. Is go change the political landscape by exercising your right to vote, right? For all, and it's your right to vote for anyone who wants to go out and vote vote on the way they feel about their issues. I think one of the things, and I don't know who asked the question, but I thank you for that, because that piqued something, that reminded me of something. One of the things that we don't talk a lot about as it relates to achieving health equity and aging is we don't talk about these political determinants of health. We rarely talk about, we talk about social determinants, environmental, biological, when in fact, by and large, the political determinants of health, they do make an impact on it. So when you want to think political determinants of health could be municipality spending and where the allocation of resources are at the local level, because quite frankly, if we want to achieve health equity and aging, and thinking about the older adults that are in the communities that we serve, quite frankly, the best approach is going to be starting at the grassroots level, right? Starting there. And I do think there needs to be a top-down approach as well, but I think there needs to be a bottom-up approach. And I think that's where the political determinants of health will certainly come into play. But I think the easiest way to do it is to engage people, to engage and encourage people to exercise their right to vote. And then once they exercise their right to vote, then I think we will be in a place, hopefully, if the vote turns out in the way in which in the one's favor, then I think it would all work out for all parties involved.
Thank you so much. Robin, do you want to put this out with a question?
You know, I'm thinking with the time, let me just see here. If we probably have time for one more question. We have let's see, a question or maybe a comment here from Susan Madison saying, I think we could adjust quality measures to more closely reflect public health concepts of risk, events, in parentheses, hazards, and vulnerabilities or capabilities of communities vis-a-vis moving away from individual racism. So more of a comment there. Yes. Okay. And then the last one question is, how do we move forward with measures that have only been validated in largely white populations? Are new instruments and measures needed? That's from Dr. Rosebush.
Yes. I can answer that real quick. Yes, I think some new instruments need to be validated, but I know that's some of the problem we have in the field, that they haven't been validated on the populations in which we are trying to serve. Yes, I agree.
Okay. Well, I just want to thank you, Dr. Thorpe. This has just been an excellent opportunity, and we've covered so much ground and learned about the things, different ways that we can look and apply the information that you've shared with us today. So at this point, we are going to break. And so this call was set up on Zoom webinar. So we will be taking it down. Any questions that we didn't get a chance to answer, I've saved those from the chat, and we'll get back with you if you had a question in the Q&A. And so we want to have everybody log off. We do have a part 2 today that will start in about 6 minutes. And that is specifically around community engagement that we've invited our community partners to. So you'll need to log in to the registration link that you received for that portion. Okay, thank you so much, everybody. And thank you, Tatiana, for having this wonderful connection with Dr. Thorpe that facilitated today's workshop.